Well, thank you, Ruth. And Ruth made reference to an initiative where Roger Williams from USP, he was the executive at the time at an Institute of Medicine workshop, accepted the challenge to attempt to develop standards for medication labels, and that's going to be the focus of my presentation this morning. So a little bit of history, and you have copies of these slides, or if you don't have them now, you will have them. So because of the short time, I'm going to be skipping through a number of them fairly quickly. They're really provided to you for reference so that you have a better understanding, or at least a place to go and look and see the type of progress that's made in this arena. So the problem is really illustrated by this label, a very confusing array of information that patients are exposed to. And this really is a typical label in the sense that historically the most prominent information on a prescription container label was always about the commercial dress. Who was the pharmacy? Was it a CVS? Was it a Target? And that was the prominent information. And now with the current recommendations, that over time will become less and less prominent on the label. As Ruth noted, we have made progress on labels. And in many cases, the progress was started even before attempts were made to standardize the label. Companies like CVS and Target, for example, went out and did work on their own, engaging people like Ruth, Mike Wolf, to assist them in designing better labels. And that predated the actual standards. And then in the very bottom, the long label, that represents the Universal Medication Schedule, the UMS format. So as Ruth mentioned, it really was the American College of Physicians Foundation white paper that kind of stimulated the interest in this topic. They had identified as key findings in their white paper that there was inadequate understanding of the prescription container by patients, and that there was a lack of universal standards. And those two prominent messages were the ones then that led to the IOM Roundtable on Health Literacy workshop, where the ACP Foundation white paper was actually released. And they had identified some key elements. And again, it's the confusion that patients face and the ultimate adverse consequences that can result, either poor adherence, adverse effects, or other issues because they simply don't understand their prescription container. Research by Mike Wolf showed that 46% of patients across all levels of literacy misunderstood one or two dosing instructions. And in terms of auxiliary labels, as Ruth pointed out, it's even worse. So this gives you kind of a summary of what appeared in the report that came out of that workshop, and I've highlighted in red two things. One was Alistair Wood standing up and giving a presentation on his concept of the Universal Medication Schedule, and a second was USP's offer through Roger Williams to convene a neutral, multidisciplinary group to actually develop prescription container labeling standards. I'm pretty sure the date on this is wrong. I noticed it this morning and I put in an email to USP. I believe it was in 2008 because the timing wouldn't be right. If it was 2007, it would have predated Roger's announcement that USP was willing to do it. But nonetheless, USP, the first step they did is their Safe Medication Use Expert Committee authorized the creation of advisory panel. And these are the charges that the committee had. And basically, it was to come up with universal standards for both the content and format of prescription labels that were a patient-centered approach to addressing the issue. This is the panel that was initially formed. I served as co-chair and continue to serve that way. Cindy Brock, who's here, was a member. Ruth was a member. Mike Wolf, who you'll hear from later, was also a member of that panel. And their work continues today. So this just gives you kind of the history of what occurred with USP. The committee was actually, the panel was actually formed in December 2008, and we published in their equivalent to the Federal Register the initial draft for the chapter 17 on prescription container labeling that had the standards incorporated in it, and that became effective or official in May of 2013. We currently are in the process of proposing revisions that will be posted for public comment from January through March of 2015. And those two revisions focus on visual impairment and more specific recommendations about patient-centered dosing. So the initial step that USP took was at a very high level. The decision was made. There was no reason to delay publishing this chapter to wait for evidence to appear. There are enough things that could be addressed and corrected even without a lot of evidence on specific things that have come out, for example, since then on the universal medication schedule. And so one of the biggest pieces of that was to simply organize the information in a patient-centered manner. And that was the key focus. So what's important to the patient is not the name of the pharmacy or what their logo looks like, but what's important to the patient are the instructions, the drug that they're receiving. How to contact the pharmacy is important, but the other details that oftentimes had focus were not important. How do you improve readability? How do you optimize typography? Simplify language? A lot of discussion and ultimately a recommendation that the purpose of the drug be included on the prescription container unless there was really a good reason for it not to be. Some patients may prefer that it not be there just for confidentiality purposes. They don't want others who may pick up their prescription to know what they're receiving the drug for. But it was a key step forward because most prescriptions never include what the drug's being given for. And for the elderly, that's a particular issue where they have 6, 7, 8 or more drugs, and they have no idea which drug they're taking for what. The auxiliary information also was a big focus of that, and the ultimate recommendation was to minimize auxiliary information, the Christmas tree that Ruth mentioned, because there was limited evidence as a basis for those. And they were very distracting to patients, and patients really didn't care about them. So it was just limiting them to those that were considered essential and evidence-based. And then the final recommendation dealt with visual impairment. So Ruth just showed you the variety of the types of interpretation that can occur. She had the same information, so I'll skip by that. So where are we now? The chapter became official in May 2013. There's a link there for you to get the details of the chapter. Again, the expectation over time is that it will become more and more specific in the recommendations that it makes in how to standardize the content and format. So right now it's at a fairly high level. So patient-centered, the patient-directed information should have the greatest emphasis. So the emphasis is on the patient understanding the instructions on how to take the drug both safely and effectively. Simplify language, so using sentence case, for example, is one of the things that were recommended out of that group. Never to use all caps because that format is very difficult to read. Using numeric representation of numbers as opposed to alphabetic representation. Giving explicit instructions, so making it clear what the dose is and what the interval is, not using terminology like twice daily, which can be easily misinterpreted and confusing to the patient. An example of how best to do that, take one tablet in the morning and repeat the information, and take one tablet in the evening. That's explicitly clear to the patient what they're supposed to do. Dosing by hours of the day was considered by the group, and there's evidence to show that patients actually misinterpret specific hours of the day as well, and that really is not a good approach. The purpose for use, again, I mentioned unless the patient has reason or the physician, the prescriber has reason not to include it. For example, for an off-label use, they may not want to include it because they're concerned that the insurance company may not cover payment if they detect what the drug is actually being prescribed for. Limit the auxiliary information. Again, both Ruth and I earlier mentioned this, and the recommendation is that these be very minimal instructions that get placed on the label. Improve readability, so pick a type font that's highly readable, use white background and black text for contrast and so on. Optimize typography. Again, a whole number of recommendations are included in the chapter. And importantly, to only have horizontal text. You will see prescription container labels where the patient literally has to rotate the container around to see the instructions. So there's a strong recommendation that only horizontal text be employed. So, what does this mean in terms of practice? Well, the important thing to remember is that USP is not a regulatory body. They don't have regulatory authority, although they have some that's specifically mentioned in federal law, but not for this particular type of activity. So the states themselves have to endorse the USP standard because that's where both the practice of pharmacy and medicine are governed. But standards of practice can apply when state regulations do not specifically endorse or preclude them. And this is where the opportunity exists for even in advance of state regulations changing to specifically recommend the use of the USP standards, that they can be adopted. And in this country, one of the biggest drivers for that was the law that was introduced first in California. If you're a national chain, and you're going to make a change, trust me, you're going to try to apply that change to as many other states simultaneously as you can. So unless state regulations preclude you from doing that, and some states have language that would do that, a national chain is going to attempt to introduce it into as many states as they can. The National Association of Boards of Pharmacy, they serve in an advisory capacity to the states. They recommended to the states to adopt this, but again, they can only recommend to the states. The states aren't required to adopt that language, but it's a very strong endorsement for NABP to have made that recommendation. Utah and New York have also adopted language in support of this. As I mentioned, the national chains are preempting that where they're able to, and then groups like the Institute for Safe Medication Practices, NCPDP, and other groups have supported it. So where are we headed? Well, the two revisions proposed for the chapter that will be available for public comment. One is incorporation of the June 2014 U.S. Access Board best practices for visually impaired. The second is to add more specific recommendations about using standardized patient-centered instructions such as the universal medication schedule. These are key recommendations that came out of that report from the Access Board, and they are reflected in what's proposed for revision. The methodology behind the UMS is to divide all dosing for oral products into 4 time periods, for example, morning, noon, evening, and bedtime. And Mike Wolf and his group have done a lot of research in support of this particular concept. And it's particularly useful for patients that are taking multiple drugs. I know my parents, when I go to visit them, they will line up cups of medications by the time, and sometimes they will have 10 or 15 cups because the prescriber wasn't paying attention. There really was no reason for them to be taking the medicines as the prescriber told them. Again, this is a representation of a label that applies the universal medication schedule. Take 2 pills in the morning and take 2 pills in the evening, and then a graphical representation, which was expected to really enhance the understanding. And that piece of evidence, I don't know if Mike's going to be talking about this later, but it didn't come out to be as strong as they thought, but they had reasons as to why it didn't. They still believe that adding the graphics should help in the understanding. This is just a summary of research that, and Mike's looking at me now, so maybe he will comment it later. This is a summary of the research that they had showing that. 2 other things that I will quickly mention. NCPDP is another group that can very quickly promote adoption. They are the group that's responsible for all of the electronic data standards that apply to medicines. They're an ANSI-accredited standards development organization. They published a white paper on acetaminophen label best practices. Acetaminophen overdosage is the largest cause of acute liver failure in this country, and most of those overdoses are completely inadvertent. So eliminating, for example, just APAP from the label was a major change, and this very quickly got adopted by the chains. Almost 90% of US pharmacies have adopted that change, including most of the major retail chains. And then the last thing I'll mention is standardizing oral liquid dosing to mLs and eliminating household units on prescriptions. And again, this is a recommendation that can become very quickly adopted. It got a lot of national press coverage, widespread endorsement by professional practice groups. Chains have already begun to adopt that, and the companies that actually publish the data that drive the prescription label generation within the pharmacy have made it very simple to convert, if a physician does write for it in household units, to milliliters. And again, there's a link down there to the USP white papers. Thank you.